So, good afternoon, everybody. Welcome to the webinar which has been held by ISTM, the SIG group, which is Blood Donor Management. And today we have Dr. Amita. She'll be talking about geospatial variations in donor selection criteria. And these sessions will be chaired by Professor Debasish Gupta, who is our Honorable President for the Society, and Dr. Sharma sir, who is the respected Secretary for the Society. I'll request Debashish sir and Sharma sir to take over the chairperson role and start the webinar. In the meantime, Dr. Amita, please share your slides.
Okay, good afternoon, everybody. I welcome you to this webinar on the voluntary blood donation, which is being organized to celebrate the National Voluntary Blood Donation Day, which was on 1st of October. Okay, the SIG group on the voluntary blood donation, I'm very thankful to them to organize this seminar on this occasion. So without losing any time, I would like to, there's any introduction slide for Dr. Amita? Anyhow, if it's not there, I can introduce
you. You can just wait.
Yeah, Dr. Amita is a straight professor working with me in the Department of Transfusion Medicine at Secretory, and she's also the award winner of the AAV President Award also in the year 2022, and she is doing a very good work in the field of the voluntary blood donation movement in the Kerala, state of Kerala, and I can vouch for that. Yeah, so and she has given a lot of awareness program over the TV and the radios pertaining to the voluntary blood donation program, and it is an honor that we are going to give a talk on this occasion. So over to Dr. Sharma for a few words.
Thank you, sir, and good morning, everyone. I think I again welcome you on the behalf of Indian Society of Medicine. And first of all, I would like to congratulate the Special Interest Group under the leadership of Dr. Suchet Sachdev and Dr. Katharia and all the members of this group who are very enthusiastic and taking forward the donor-related issues in a very comprehensive manner. And blood donor management is one key area, basically, which takes the donor issues, starting from their health till the management of adverse transfusion reaction, adverse donor reactions, and follow-up post-test notification, and then further referral to specific treatment if they are found reactive in any of the transfusion transmissible infectious agents, or if they are found basically anemic, or how to guide them, provide the guidance, because this is the need of the hour. Because if we are going to emphasize on regular repeat blood donation, then blood donor management is the only answer. Because if we don't think now in terms of blood donor management, it will be a challenge. It will be a great challenge for us to improve our regular repeat donor base. So I think today we have, as Professor Debashish sir has mentioned, a very learned speaker on this, Dr. Amita, Associate Professor from Sri Chitra Medical Sciences University Institute. So she shall be highlighting various key areas where I think as young professionals, all of us who you have joined, can pick up one and start working on that. So now, if the chair permits, I can hand over the floor to Dr. Amita.
Yes.
Thank you, sir. Yes, Dr. Amita, please.
Good morning, everyone. And thank you, Gupta sir and Sharma sir, for the kind introduction. Thank you so much, sir. So the topic given to me is for this webinar series is the geospatial variations in the selection criteria of blood donors. So in this presentation, we'll be looking at the selection criteria of blood donors across the continents. What are the variations? What is the commonality? And is there a scientific basis for this? So the primary responsibility of the blood transfusion services is to provide safe, sufficient, and timely supply of blood and blood products. The blood transfusion service should ensure that the act of blood donation is safe and causes no harm to the donor, and the products derived from the donated blood are safe and efficacious for the recipient. The purpose of the blood donor selection guidelines is to protect the donor health and safety by collecting blood only from healthy individuals, ensure the patient safety by collecting blood only from those donors whose donation, when transfused, will be safe for the recipients, identify such factors which may make an individual unsuitable as a blood donor, either for a temporary period or permanently, and it is also our responsibility to reduce unnecessary deferral of safe and healthy donors. So all deferrals should be based upon scientific and logical reasons. And we also have a responsibility to ensure the quality of the blood products that we collect from these donations and minimize the wastage of resources by not collecting from unsuitable donors. So most of the guidelines across the continents which are now existing are loosely based upon the blood donor selection guidelines developed by WHO on assessing the donor suitability for blood donations. So this was developed in the year 2012, and it was developed based upon the existing international and national guidelines of that time. So the inputs were taken from the European Union, the UK guidelines, the US Food and Drug Administration, the Australian Red Cross Blood Services, and the Health Sciences Authority of the Singapore. So the WHO guidelines on assessing the donor suitability for blood donation states that there is a paucity of high quality evidence to base the decisions of the donor selection. The randomized control trials, which are the major tool for an evidence-based medicine, cannot be applied to the donor selection because it is unethical. So all these guidelines are based upon few published clinical, epidemiological, and observation studies and a few systematic reviews and audits on the criteria for the blood donor selection. And there is significant variations in the donor selection criteria between countries and even in its implementation. So the recommendations given by WHO are based upon the international best practice and knowledge existing at that time and the expertise of the members of the guideline development group and the external review group. So for my presentation, I have taken, apart from the WHO guidelines, which was last updated in 2012, I have taken guidelines from the US, that is the FDA, and the AABB Donor Health Questionnaire, which was last updated in May 2023, the Pan American Health Organization PAHO 2020 guidelines, the United Kingdom JPAG Blood Donor Selection Guidelines last updated in 2021. From India, the guidelines for the blood donor selection and blood donor referral last updated in 2017. From the Japan Red Cross Society Guidelines 2023. And also I have referred to the published literature from the PubMed. So coming to the general principles of the donor selection. Only individuals in good health should be accepted as donors of blood and blood components. The selection of blood donors should be based on a regularly reviewed selection criteria. Hello, is my slides moving and visible?
Yes, it's moving. You have, yeah. Okay.
Prospective donors' health status and medical history should be evaluated for each time on the day of donation prior to the blood collection. The blood transfusion service should provide appropriate donor information and a simple donor questionnaire for the health and risk assessment and obtain the donor's informed consent to blood donation. The staff at the BTS should be suitably qualified and trained in the donor selection process. There should be good communication between the BTS staff and the blood donor, and donor confidentiality should be assured. And BTS also has a duty of care to provide counseling to all the deferred donors and referral for their further management. So this is the normal flow chart of a blood donor selection process. So the steps in the donor selection process includes the donor registration. After the donor registers, they are provided with the pre-donation information, going through which they can either self-defer or go further and complete the donor questionnaire. And reading or filling up the donor questionnaire, they can also think that they might not be a suitable donor, and again they can self-defer, or they can proceed forward for the donor interview and the pre-donation counseling, in which they are provided all the information. And during this step also they have the option of self-deferring. After that, the donor's health and risk assessment is done by the counselor and the medical physician, and they are again given an option of self-deferral. After that, the donor is allowed to sign the informed consent, and then the donor may be either accepted for blood donation or they may be deferred from the blood donation. If the donor is deferred from blood donation, the donor should be told the reason for blood donation and the period of the deferral, whether it is a temporary deferral or it is a permanent deferral, and if required, they should be referred for further management in situations. Now, if the donor is accepted for blood donation, then after donation, the donated unit is screened for the relevant transfusion transmitted infections in the donated sample, and then if the donation is found to be reactive for any of the relevant TTA markers, then again the donor is contacted, counseled, and referred for appropriate management. Only the non-reactive donations are taken into the inventory. So this is the general steps in the donor selection process. So now we will look at some of the general criteria for the selection of the donor. First and most important is the age. So most countries keep a lower age limit for blood donation, and this is set considering the country's legal requirements for consent and also based upon the evidence that there is increased risk of vasovagal reactions in young donors and young individuals. Young menstruating females and adolescent individuals may have increased iron requirements. So the lower age limit for blood donation in most countries is 18 years. Some countries, they permit 16 to 17-year-old also to donate if they fulfill the other selection criteria and parental consent is obtained. There are several studies which show that there is increased rate of vasovagal reactions in young donors. So we have to be very careful when we take or accept the donations from the young individuals. The upper age limit for blood donation in most countries is between 60 to 70 years. And this is based upon the healthy life expectancy of the population, the increased incidence of cardiovascular disease with increasing age, and the potential risk of adverse reactions in the older individuals. The usual upper age limit for a regular blood donor is 65 years, and for a first-time donor, it is accepted up to 60 years. The donors over the age of 65 years may be accepted at the discretion of the responsible physician. In some countries where the healthy life expectancy is high, for example, the Canada, New Zealand, England, and the United States, they do not have an upper age limit, and that has been removed for a regular blood donors. In Australia, the upper age limit is kept at 80 years. And all this is based on the evidence that vasovagal and other adverse reactions are infrequent in all donors who fulfill the otherwise normal donor selection criteria. So this is a study published from the BEST collaborative group study, and this has looked at the donor deferral patterns in these high developed countries such as the Canada, New Zealand, England, and the United States. And if we look at the donor deferral pattern, if we look at the US donor deferral of the females in the age group more than 70 years, the deferral is almost comparable to that of the individuals of females below the age of 70 years. So there is not much difference in the donor deferral rate between females more than 70 years and females less than 70 years. Coming to Canada, actually, the deferral is less in the elderly females as compared to the females less than 70 years. Now, we look at the age criteria in our Asian countries. So the minimum age is kept at 16 years in countries like Hong Kong, Japan, Korea, and Singapore. Whereas Mongolia and Taiwan, they have a minimum age criteria of 17 years. Now, for a maximum age at first donation is kept at 66 years in Hong Kong, followed by 65 years in Taiwan and 64 years in Korea. And maximum age for a repeat donation, they can be accepted up to 76 years. So it is 16 to 76 years in Hong Kong, whereas it is 16 to 69 years in Korea. Mongolia, it is 70 to 60 years. Singapore, it is again 16 to 75 years. And Taiwan, it is 17 to 69 years. In India, our criteria is from 18 to 65 years. Next, coming to the body weight. So the weight limits are set for blood donation to protect the donors from adverse effects such as vasovagal reaction and anemia, because low body weight and blood volume are found to be independent predictors for development of vasovagal reactions. And it is generally accepted that the volume of whole blood donated should not exceed 13% of the total blood volume. So based upon this, a donor should weigh at least 45 kg to donate 350 ml and 50 kg to donate 450 ml blood. Usually, no defined upper weight limits are kept for blood donation, but gross obesity may be considered as a reason for deferral if the veins are inaccessible, if the donor's weight exceeds the safe loading capacity of the blood collection bed, or it impairs the capacity of the blood transfusion service staff to provide care in the event of the donor developing an adverse reaction. We can defer the donor because donor safety is also very important. And another more important reason is that the blood volume may be overestimated in obese individuals. Usually, we estimate the blood volume using the Nadler's formula. So, the fat contains proportionately less blood than the muscle, and hence there is a risk that the blood volume may be overestimated and the donor can have an increased risk of developing an adverse reaction. So, if we look at the weight criteria, Hong Kong has kept a minimum weight of 41 kgs for the male donors. That is a minimum weight. And if we look at the volume, the standard volume is 450 ml in Hong Kong. But for a donor between 41 to 50 kg, they go for a 350 ml collection. Japan, the minimum weight is 45 kg. In Singapore also it is kept at 45 kg. And Taiwan, for the females, it is kept at 45 kg. Then in India, the minimum weight is 45 kg. Between 45 to 55 kg, we go for 350 ml. And more than 55 kg, we go for a 450 ml collection. Some countries also have restricted the maximum volume that can be donated per year. For example, in Japan, for a male donor, they can collect up to a maximum of 1200 ml per year. Whereas in Korea, the volume is set at 2160 ml in a year. In India, we do not have such a guidelines. Now, looking at the hemoglobin and the iron status. So, the hemoglobin screening safeguards the anemic individuals from donating blood, and also it ensures the good quality of the blood components. From each blood donation, removes approximately 236 milligram of iron from the body. So we need to protect our donors from donation-induced iron deficiency. And since we do not have a rapid, simple, and direct methods to estimate the iron status, we go for the pre-donation assessment of the donor hemoglobin. And the limits of acceptable hemoglobin for blood donation should be so set that it prevents selection of anemic individuals and also minimizes exclusion of the healthy donors. The WHO defines anemia as hemoglobin less than 12 gram per deciliter for a non-pregnant woman and 13 gram per deciliter for a male. So based upon this, the minimum hemoglobin levels acceptable for a blood donor is recommended at 12.5 gram per deciliter for a female and 13.5 gram per deciliter for a male. In some countries, for example, India, the same hemoglobin levels may be used for both the males as well as the females. And it is very important that the donor hemoglobin and or hematocrit should be measured immediately before each donation using a validated technique which can be subjected to quality control. Now, this is the hemoglobin screening criteria in different guidelines. So as per the US FDA, it is 12.5 gram per deciliter for both males as well as females. ABB, they say a hematocrit of 38%. UK, again, it is 12.5 gram per deciliter for a female and 13.5 gram per deciliter for males, corresponding to a hematocrit of 38% and 40% respectively. European Union also, the guidelines are the same. In Japan, they have a criteria of 12 gram per deciliter for 200 ml collection and 12.5 gram per deciliter for 400 ml collections from females, and 12.5 and 13 gram per deciliter for 200 and 400 ml collections from males. In India, we have the uniform criteria of 12.5 gram per deciliter for both males and females. Now, this is taken from a study which shows the graphical representation of the lower limit of hemoglobin values. This is for the males. So if we look within the US itself, US blood centers, some centers, they have kept a minimum hemoglobin level of 12.5 gram per deciliter for the males, whereas other blood centers in the US and Brazil, they have kept a minimum hemoglobin of 13 gram per deciliter for the males. Some countries, such as the European countries, such as Finland, Lithuania, Romania, Belgium, etc., they have kept it 13.5 gram per deciliter for the males. Similarly, if we look at the females, in Hong Kong has kept the lowest limit at 11.5 gram per deciliter. That is the Hong Kong. Then New Zealand, Australia, Canada, etc. New Zealand, Australia, France, they have kept it 12 gram per deciliter for the female. There is a minimum hemoglobin. And other countries, most of the other countries, they have kept a limit of 12.5 gram per deciliter for the female donors to be eligible for blood donation. Most of the countries, they do not have an upper cutoff limit for the hemoglobin values. Some countries like Hong Kong, they have kept a hemoglobin range between 13 to 18 gram per deciliter for the males. And for the females, they have 11.5 to 16.5 for the females. The upper limit is 18 for the males, and for the females, it is 16.5 gram per deciliter. There is a Hong Kong guidelines. Similarly, Singapore also has kept an upper limit. It is 18.5 gram per deciliter for the males and 16.5 gram per deciliter for the females. Most other countries, they have not kept an upper cutoff limit for the hemoglobin. The method of blood sampling and hemoglobin estimation is also important. So most of the countries, they go for a capillary sampling via the finger prick using a hemoglobinometer. In United Kingdom, they go for a copper sulfate method using the capillary blood. And if the values are less or the drop floats, then they go for hemoglobin estimation in the venous samples also. In Australia, they go for the pre-donation capillary sample testing. And if the hemoglobin comes below the cutoff or there is a decrease in hemoglobin of less than 2 gram per deciliter, then a venous sample is tested on the hemoglobinometer. In Israel, they go for a pre-donation hemoglobin measurement in all female donors and only in vegan or vegetarian male donors. Some countries, such as France, Belgium, and Denmark, have also started a post-donation hemoglobin testing in the venous sample. And if they find that the hemoglobin levels are low, then the interdonation interval is prolonged or the donors are provided with iron supplementation. Then next, coming to the frequency of donation. So the maximum number of donations per year is determined by the minimum interdonation interval. The minimum interval of 56 days is followed in most of the North American countries. And with a minimum interdonation interval of 56 days, they allow for a maximum of 7 donations per year for both males as well as females. Whereas France and Belgium, they also have a minimum interdonation interval of 56 days, but they allow for only maximum of 4 donations per year from the female donors. Hong Kong and Australia, they have kept a longer interdonation interval, particularly for the young donors. And in Switzerland, the donation time or the frequency is higher in the postmenopausal females compared to the premenopausal women. And studies have shown that without iron supplementation, keeping an interdonation interval of 56 days is very likely to be inadequate for a full recovery of hemoglobin after donation. So this shows the minimum hemoglobin values required for the males and females to be eligible for donation and the interdonation intervals and the number of donations they can do per year. So if we look at Hong Kong, the males it is 13 and in females it is 11.5 gram per deciliter. So the interdonation interval is kept at 75 days for the males and 105 days for the females. They allow a maximum of 5 donations from the males and 4 donations from the females. Singapore and Australia, they allow a maximum of 4 donations in a year with a donation interval of 84 days. Then Israel, they allow for 120 days of interval between the donations and allow for a maximum of 4 donations per year. Within the Canada itself, they allow for 56 days is the interdonation interval and they allow for maximum of 7 donations from both males as well as females. Within the United States, most of the blood centers, they allow for maximum of 7 donations from both males and females with an interdonation period of 56 days. But the Mayo Clinic, they allow for only 4 donations in a year with an interdonation interval of 84 days. Now, this is a graphical representation which shows the hemoglobin levels and the maximum donations allowed. So, countries like Netherlands, England, and Spain, which keep an hemoglobin cutoff of 12.5 gram per deciliter for the females, allows for a maximum of 3 donations per year. Then, countries like Denmark, France, New Zealand, Finland, Australia, Belgium, Israel, Hong Kong, they allow for a maximum of 4 donations from the females, whereas the US blood centers in the US and Canada, they allow up to 7 donations from the females per year. So this is again from the Asian countries. We can see the number of donations, maximum number of donations permissible per year. So in Japan, they allow for only 2 donations from females in a year, and a maximum volume of 800 ml is permitted. Whereas most other countries, they have between 4 to 6 donations are permitted. Mongolia allows for up to 6 donations per year from the males. In India, for the males, we allow for maximum of 4 donations in a year, and for the females, it is 3 donations in a year. Then, coming to the monitoring of the iron status and iron supplementation. So, as per the blood programs in Switzerland and Denmark, they routinely monitor the donors' iron stores using the ferritin assays. So Switzerland measures ferritin in all whole blood donors at every donation, and usually the values are determined and reported typically the very next day of donation. And they actively inform the donors when the ferritin values are less than 10 nanogram per ml, or there is a fall in the hemoglobin from the previous donation. And the donors are contacted and they are counseled with either of the 3 options. That is, they can increase the interdonation interval, or they can go for iron supplementation, or they can go for dietary modifications. In Denmark, the ferritin screening is performed only at the first donation and then every 10th donations, or more frequently if the hemoglobin values are falling. And some of the blood centers, they provide the iron supplementation without ferritin screening, and approaches may include supplementation for all donors, or supplementation for all repeat regular donors, or supplementation in all female donors of the childbearing age group, or only for those donors who fail their hemoglobin test. So, this is showing how the ferritin estimation is done. For example, in Hong Kong, they go for a random selection of 100 donors per month in whom they go for a ferritin estimation. Whereas in Singapore, if your hemoglobin values have failed more than 2 times, the ferritin estimation is done. In Australia and Spain, it is for a if you fail the hemoglobin minimum eligibility of the hemoglobin donation, the ferritin estimation is done. The countries such as the Denmark, Belgium, France, and Malta, they offer the post-donation hemoglobin measurement, and also they advise the iron supplementations according to their algorithms. Next, coming to the volume of blood donation. So the volume of blood that can be safely donated is directly related to the donor's blood volume. And as we have already seen, the volume of the whole blood donated or an apheresis procedure should not exceed 13% of the donor's total blood volume. But we also know that accurate blood volume measurements are very difficult. For example, blood volume may be overestimated in an obese individual. Coming to the volume collection. So there is a standard volume which is collected. For example, it is 450 ml in Hong Kong. It is 400 ml in Japan, Korea, Mongolia, Singapore. Again, it is 450 ml, and in Taiwan, it is 250 ml. But then smaller volume bags are also available for individuals with a lower body weight. For example, in Hong Kong, we have a 350 ml bag. In Japan, 200 ml bags are available. And in Taiwan, even bigger volume bags such as the 500 ml bags are also available. So this is a table which shows the consolidated data regarding the volume of whole blood donations across the countries, the allowed donation intervals, the minimum and maximum age for donation, the minimum hemoglobin requirement, the minimum weight requirements for donors across countries. So we have the American guidelines, Canadian guidelines, then we have the from the New Zealand, we have the Hong Kong, South African. So the guidelines varies across the countries. Next, we look at the vital signs. So a normal pulse rate means 60 to 100 per minute, and regular rhythm are indicator of a good health. And many blood transfusion services recommend that the pulse rate should be examined prior to donation. But the catch is that the ability to detect significant abnormalities of the pulse rate or the rhythm depends upon the skill and experience of the staff. And if it is not done by a physician, it is most likely to be missed. And the usefulness of this examination in a blood donation setting also needs to be assessed. Body temperature. A donor who is febrile is truly unwell and should be deferred from donation. Next, blood pressure. So normal blood pressure says systolic is between 120 to 129 millimeters of mercury, and diastolic BP is between 80 to 89 millimeters of mercury, and this is regarded as an indicator of good health. And higher levels of blood pressure is usually taken as a deferral criteria on the basis that uncontrolled hypertension can be an independent risk factor for cardiovascular disease. But they also state that blood collection session is not the ideal setting for a BP recording because it may increase the anxiety of the donor, and you cannot label a person as hypertensive based upon a single reading. So let us look at the vital parameter estimation or incorporated in the donor selection guidelines in countries. For example, Canada and United Kingdom, they measure the blood pressure of their donor only at the first donation, and after that they do not take the BP recordings. And they also state that the donor, even though the BP will be measured, the donor is not deferred from donating for an out-of-range blood pressure. Similarly, in Canada and United Kingdom, the donors are not deferred because of a low body temperature, but certainly when the body temperature is high, they are deferred. In Dubai, the blood pressure should be between 50 to 100 diastolic and 90 to 180 systolic for eligible for blood donation. In New Zealand, they state that the blood pressure should be adequately controlled and stable and should not have a postural hypotension. But they do not give any values of the blood pressure. In Japan, they accept pulse rate up to 40 per minute and between up to maximum of 100 per minute. And blood pressure systolic can be between 90 to 180 and diastolic can be between 50 to 110 millimeters of mercury. In India, we have between 100 to 140 and diastolic is between 50 to 90. Pulse rate of between 60 to 100 is accepted for a donation if the rhythm is also regular. So as we see, there is wide variation in the acceptance criteria and in the readings of the pulse rate and the blood pressure across the countries. AABB also has stated guidelines, but they also state that donors with a BP or pulse rate outside the range can also be accepted by the blood center physician. So that depends upon the blood center physician's discretion. Next, coming to the gender. So we look at the females in the state of pregnancy, lactation, and menstruation. So WHO states that female donors should be deferred during the pregnancy and for a sufficient time after delivery or following abortion and lactation to allow for the recovery of the iron stores. Menstruation is not considered as a reason for deferral. In India, pregnancy we defer for 12 months, abortion 6 months, menstruation and for a lactating mother for the period of menstruation or the lacting or the feeding. As per the UK guidelines, a lady must not donate if she is pregnant and less than 6 months since delivery or termination. New Zealand, it is pregnancy is up to 9 months after delivery, abortion is 3 months, and for menstruation there is no deferral. Next, coming to the very important travel history. So the WHO blood donor selection criteria differentiates between the donors who have traveled or have resided in an endemic country or visited an endemic country or a non-endemic region for the selection and deferral to ensure the blood safety. And we look at these emerging infections such as the dengue virus, chikungunya virus, West Nile virus, malaria, Chagas disease in this section. So the strategy is to identify the at-risk donors by eliciting information on their travel history, then have an up-to-date knowledge on the disease epidemiology, which are the endemic and which are the non-endemic regions of the world. And then we can implement deferrals ranging from up to 28 days to 6 months when we do not have a screening test. And always the deferral should be balanced against ensuring a sufficiency of the blood supply. So this is the West Nile virus, geographical distribution of West Nile virus. Countries which are highlighted in orange are the countries which are known to be endemic or have outbreaks of the West Nile virus. And a study done in 2013 found that the risk of West Nile virus transmission was much higher due to a local outbreak than by the traveling donors. So based upon this, the US implemented a pooled NAT screening of the blood for the West Nile virus in 2003. UK and Australia, they had a donor deferral criteria of 28 days. But after 2009, they have also started implementing the NAT testing for travelers and during the peak seasons between July to November. Our NBTC guideline states for a 4-month deferral. Next, coming to dengue. So these tropical countries highlighted in the orange color are the countries where dengue outbreaks have been reported and maybe endemic. So as per WHO, endemic countries, the deferral is for 6 months following full recovery from the infection. And for non-endemic regions, we can defer if there is only a visit, and if the infection has developed, it is a deferral for 6 months. So for a visit to a non-endemic region, there is a deferral for 28 days. And if the person has developed infection, then after recovery, 6 months of deferral should be given. As per AABB, a visit to an endemic area, deferral of 120 days after resolution of symptoms. And NBTC, because India comes under the endemic zone for the dengue, we have a 6 months deferral after infection and 4 weeks after visit to an area where the dengue outbreak has been reported. Similar, the guidelines are very similar for the chikungunya also, and the countries highlighted in the green color shows the chikungunya outbreak or endemic regions. Next, coming to the Zika virus. So in the Zika virus, United States already has a NAT screening for the Zika virus. United Kingdom, they have a deferral of 28 days since return from the affected area, and in infected individuals, the deferral is for 6 months. In India, we have a deferral of 4 months following either infection or travel to a Zika endemic region. Next, coming to yellow fever. So parts of Africa and parts of South America, they are known to be endemic for yellow fever. So if we travel to these countries and have taken vaccination, which is a live attenuated vaccine, then we will be deferred from donation for 28 days as per our NBTC guidelines and the WHO guidelines. Next, coming to Chagas disease. So some parts of South and Central America and parts of US, Canada, they have reported sporadic cases of Chagas disease. So, and there is an antibody test available for diagnosis of Chagas disease. So as per the WHO and PAHO guidelines, in endemic countries, individuals who have ever had a diagnosis of Chagas disease are permanently deferred from donation. And all these endemic countries, they have gotten universal mandatory screening for the Trypanosoma cruzi, which causes the Chagas disease. In non-endemic areas, if a screening test is not available, then a donor who has had a diagnosis of Chagas disease should be deferred permanently. And in non-endemic countries where the screening test is available, they can be accepted 6 months after last return from the endemic area, provided they test negative in the screening test. So this is a study that was done, which has looked at the international travel and blood donation, the risk and restrictions. And apart from the infections which we discussed, they have also highlighted some emerging infections such as yersiniosis, babesiosis, and leishmaniasis, which can also threaten the blood safety. So against yersiniosis, there is no vaccine available, and they are advised for a deferral of 28 days following full recovery, but no guidelines exist. In babesiosis and leishmaniasis, because of the chronicity of infections, they are asked to permanently defer such donors. Now, they have also said that the globalization has resulted in people of all ages traveling further and beyond. And certainly this carries or brings in a risk to the safety of blood transfusions. But the current method of blanketly excluding all the donors with a travel history precludes a significant number of potential donors from giving blood. So they have asked to go for an evidence-based assessment of the risk and benefit and go for the use of a sensitive geomedically selected laboratory screening methods wherever possible to safeguard the blood donations. We look at the sexual behaviors. So as we know, from traditionally, we have believed that certain sexual behaviors are shown by data to be associated with high risk of transmission of HIV, hepatitis B, and hepatitis C. And certainly the blood transfusion service needs to identify and defer such donors. So the deferral policies for these high-risk behaviors should be supported by public education so that the donors self-defer without the need for the BTS staff to go for a detailed, intrusive questioning about the individual's sexual behavior. And the deferral criteria for the high-risk sexual behavior is depends upon the selection criteria in the country based upon the residual risk of the TTID, considering the changes in the disease epidemiology and improvements in the available technologies for the donation screening and the ongoing research. So this is an update with the males with MSM behavior. So there are certain countries which have permanently banned such donations from such individuals, such as India. There are countries which have implemented a 1 year to 6 months deferral. For example, the European countries have a 1 year to 6 months deferral, and certain American countries, they have a 4 to 3 months deferral, depending upon the technology that they use and the disease epidemiology in the country. Now, many of the countries, they are moving towards what is called as individual donor assessment, in which all the donors are screened based upon an individual donor assessment method, regardless of the sexual orientation or the gender identity, to reduce the risk of transfusion-transmitted infections. So as of today, 12 countries have already moved in towards the individual donor assessment. Next, we look at briefly about certain medical conditions. This is again a best collaborative study which has looked at the medical conditions and the deferral criteria based in America, Europe, and other countries. So if we look at these guidelines, we find that North America usually takes a liberal policy towards the acceptance of these donors, whereas Europe takes mostly a restrictive or a deferral attitude towards these metabolic conditions or the medical conditions. And with the deferral criteria also there is variations. For example, cancer, some of the cancers such as the breast, colon, and prostate cancers, if it is detected early and the disease has been cured, after 1 to 2 years, it can be accepted in USA, whereas 5 years is the deferral period in other countries. Similarly, for an epilepsy, in North America, they have kept a seizure-free interval of 1 to 6 months, whereas in other countries, the deferral period is 3 years. So the scientific basis of these needs to be reviewed. So coming to the future directions. So the future stands for the evidence-based practice. We cannot go on arbitrary criteria for the donor acceptance or donor deferrals. So it has to be evidence-based practice. And some studies in this direction are the TRANSPOSE study, which is a study from the Europe, which stands for European Transfusion and Transplantation Protection and Selection of Donors Project. So this is undertaken by the European Directorate for the Quality of Medicines in Healthcare, and it is to change the donor selection guidelines after doing a comprehensive risk assessment and also at looking at the impact on the blood supply and the cost involved. But they have also stated that there is a need to establish a tolerable risk level with respect to both the donor and the recipient safety. And second is the REDS program, which is an ongoing program in the US. It stands for the Recipient Epidemiology and Donor Evaluation Study. This was funded by the NHLBI, and the aim is to protect the US blood supply through research to improve the blood component safety and effectiveness of the transfusions. So the advantage or the biggest point of this REDS program is that they have got a biologic specimen and data repository information available. And based upon this, they conducted the REDS 1 trial, which looked at the retrovirus infectivity and spread through the blood transfusions. The REDS 2 trial, which looked at other emerging infections and other transfusion-transmitted infections. The REDS 3 trial looks at the adult transfusion recipient epidemiology, and the REDS 4 trial is on the pediatric population. So based upon the outcomes of these studies, they were able to bring in technological advances and updating the donor selection criteria. For example, the pathogen reduction technology, FDA gave approval based upon the REDS program. Similarly, the NATCH testing for the Zika and Babesia was started in the US blood supply, again based upon the outcomes of this REDS program. In US, again, they have got a national blood safety surveillance project also going, under which they have a transfusion transmissible infection monitoring system. And this is a comprehensive monitoring system for TTIs in the US blood donors. So the data is collected and analysis are done to support the policy changes. And in the TTIMS also, they have got 2 coordinating centers. One is the Donation Database Coordinating Center, which collects the data on the donations and test data during the routine blood donations. And then there is a second one, which is called the Laboratory and Risk Factor Database Coordinating Center, which collects samples from all consensus positive and even false positive donors. And then it serves as a repository the follow-up molecular testing is done and other testing for the infections is done. So based upon these studies, they have been able to regularly update the donor selection and deferral criteria. And another is the best collaborative study, which is a collaborative study between Germany, Netherlands, UK, and Australia, Canada, and US to look at important donor-related issues and generate evidence-based results. So we hope in the future these evidence-based outcomes, study outcomes will be available, and we will be having more scientific basis to depend upon for our donor selection and deferral rather than these arbitrary criteria followed across the countries. Thank you.
Thank you, Dr. Amita, for giving a very good presentation of the donor selection criteria across various countries in the globe, and very well taken in all particular aspects of the donor selection criteria. Before I think I will ask Dr. Rahul to moderate it, and there are many questions by the participants there in the chat box. I think Dr. Rahul, you take it over, and then I'll give my comments later on.
Thank you very much, sir. Dr. Amita, it was a wonderful presentation. We do have some questions in the chat box. Can you access it, or should I?
Yes, I can access.
So I think you can go on asking one of the questions so that she can address all those.
There's a question by Dr. Sudha. She's talking about range of hemoglobin, particularly the upper limit for blood donation. Basically, what is the cutoff criteria if we have the upper limit?
So as we have seen, most of the countries, they have not kept an upper limit of the hemoglobin cutoff. But some countries like the Hong Kong have kept an upper limit of around 18, and some countries have kept it 18.5. But in India, I think we do not have an upper cutoff limit, and it is left to the blood centers to decide based upon their experience and develop their own SOP for keeping an upper cutoff limit for the hemoglobin.
Okay, I will put a comment on this. Okay, recently we have a TRG meeting where we have reframed the donor selection criteria, where we have taken the issue of the upper cutoff value of the hemoglobin. As of this criteria, the cutoff value for the males are 18.5 for the secondary polycythemia. Okay, 18.5. Primary polycythemia will be permanently deferred. Secondary polycythemia is 18.5 for male, and for female it is 16.5. Now this has been we have done all the amendments, and it will be soon published by the DGHS. Okay, thank you.
Thank you, sir. In continuation of this question, there's one more question which is related to it. It has been asked by Dr. Anand. Says that in India we have a cutoff of 12.5 gram per deciliter of hemoglobin as for donation. But according to WHO, a male with a hemoglobin of this level is considered anemic. So what exactly is the criteria for choosing 12.5 as the cutoff value? That's a question by the attendee.
So in India, we do not discriminate based upon gender for the hemoglobin levels. We have kept a uniform criteria of 12.5 gram per deciliter for both the males as well as the females. But as you rightly stated, based upon WHO, this becomes looks as an anemia for a male donor. So that is certainly true. So while we take a donor, these are all guidelines. These are the guidelines which are to guide you. But you can always take a decision we can always take a decision. So if you think a male is likely to become anemic after donation or the hemoglobin values are just around the 12.5, you can advise. While you can accept the donor, you can also advise them for the iron and folic acid supplementation or to get investigated for the anemia. So that is, I think, sir wants to add something, sir?
Thank you. I hope this has answered your question, Ran. So moving on to the next question, there's a question, can a stable person with Gilbert syndrome donate?
Yes. A person with a stable person with Gilbert syndrome can donate blood. It is acceptable for donation, provided that at the time of donation, he is not jaundiced or he is not icteric. So you do a general examination, look at his conjunctiva and see that he does not have a yellow conjunctiva. If there is a yellow conjunctiva, certainly you have to defer the donor. But if it is not there, then and he has gotten documented report of having a Gilbert syndrome from a physician, certainly you can accept the donor.
Yes, I agree with that. And in the session also, we have discussed about the Gilbert syndrome because it is not a very problematic case. Okay, so we can, we're not going to, it is a, select the Gilbert syndrome, but what Amita has told that, yes, at the time of the donation, whether the patient is having the icterus or not, that has to be looked into, and then we can defer as per the criteria for the history of the icterus. Okay, otherwise Gilbert syndrome is not a case of a rejection.
So similarly, on those lines, one more, a person with history of poliomyelitis can donate. There's a question again on
Yes,
the
yes.
history.
The history of poliomyelitis, it is a very specific disease about which actually we do not have a clear-cut guidelines. But as per our Indian guidelines, they say that if following a poliomyelitis, the person suffers a neurological deficit, then actually he should be deferred from donation. That is what, like that only they have said. It has not been specifically mentioned.
Now poliomyelitis is eradicated from India.
But
So
recently, I think in the Northeast, there was an outbreak of poliomyelitis.
But it was not very much, but it is now totally at the Pulse Polio program, we have been able to get eradicated.
Hopefully, in the future, we will not be seeing.
That's okay.
Thank you so much. Moving to the next question, what exactly is the interval between granulocyte or a PBSC donation, between two donations of granulocyte or stem cell?
Yes. So actually, in this presentation, I have just looked at the whole blood donations, criteria for the whole blood donation. Then in the subsequent webinars, we'll be coming across the specific donations also. The granulocyte and the PBSC donations also will be taken up by the ISTM SIG group. Okay. So at that time, we will be able to get the details from the other countries also.
Sure. Thank you.
This also has been taken into consideration in the donor selection criteria, and it will be released, as Amita rightly pointed out, when the topic of the blood component donation will come, that time there is an issue. But we will soon get the revised blood donation selection criteria, where all these issues of the apheresis, granulocyte, and the double red cell donation, everything has been taken, the time interval, and how many times they can donate in a year.
Thank you, sir, for apprising this status. So moving to the next question, can a person with hypothyroidism donate? And now that hypothyroidism has a high incidence, that is 1 to 2 people tend to have 10, I think. It's basically somebody who's taking Thyronorm, and what should be the cutoff for Thyronorm, and if there is a history of hypothyroidism, should we take the person for donation?
So as per the Indian guidelines, we require thyroid function test to be normal before we accept the donor. Hypothyroidism, certainly if the person is hypothyroid, there will be the response to the reactions will be delayed. And so we have the donor is at risk of developing an adverse reaction and not getting his responses adequately at time. Whenever a donor develops a vasovagal reaction, our central system gets activated and we have a response to a vasovagal reaction. So when a person has an hypothyroidism, his response rates will be delayed. So we are putting the donor actually at risk. But following, if the person is taking Thyronorm, supplementation is being taken, and the thyroid function status has come back to the normal, and it is not, the hypothyroidism is not because of an autoimmune etiology, I think the donor can be accepted.
Thank you, Dr. Amita. So moving to the next question, can a stable person with Rotor syndrome donate? Rotor syndrome donate blood?
I think that person asking means similar to the Gilbert syndrome, I think.
Yes, Gilbert syndrome. Yeah.
So I think that I have already answered. So you have to do a general examination and you have to have a documented proof that this particular condition. And the person does not have a liver dysfunction.
Okay. So similarly, that does L-proxin acceptable for donation, which comes for hypothyroidism, so which has been addressed. If an Indian, moving to the next question, if an Indian stayed outside India for a few months, then returned to India, then what is the deferral period? It's basically my short travels across.
Yeah, short travels. So this is an area in which we need to come up with more guidelines. Actually, our Indian guidelines have addressed only with regarding to the Zika virus and the West Nile virus. They have stated a 4 months deferral. So WHO states that if the person has visited an endemic region, then it is better to defer for 28 days. And if the person has developed an infection in the form of a febrile infection, then it is better to defer for at least 6 months. So that is a general blanket rule that applies. But I'm sure in the coming years, we will have more updated guidelines, as Gupta sir is already stating. So the travel guidelines, I think the updated guidelines will come in soon.
Thank you. So I think this addresses one more question which was there. Ki what should be the deferral criteria for a person who has gone for a week-long vacation outside India? Dr. Vinay, I think this will help with the question. Now, again, there's addition which Gilbert syndrome has already answered. I hope this will, Dr. Debasish, this will help you understanding the question which you have been put. I'll just put a bit of, if not diagnosed with Gilbert, after donation, yellow discolored plasma is observed. Hence, tested for bilirubin. What will be the higher limit for bilirubin for deferral? That is a question which they had put in. The doctor, I think that has been already answered. If you don't usually test for bilirubin after the donations. Amita, what's your take on it?
Yeah, exactly what sir also said. Like if you find any discoloration in the plasma, as per our guidelines, we have to discard that unit and not take it for the transfusion.
Yes, any discolored plasma should be rejected.
So moving to the next question. If it is not a known case of polycythemia, that is primary or secondary, a donor with a high hemoglobin, say 17 or 18, should be. I think Debashish sir has already answered this thing that we'll have a SIT criteria, and according to the levels, very soon we'll have the norms written in our act. So again, men having safe sex with men can be eligible for blood donation. I think Dr. Amita has already shared. She can.
Yeah, as per our current status, such donors are permanently deferred from donation. So it is very important to elicit this history from all male donors. We, like from the physical appearance, we may understand the person is a transgender, but a person having an MSM, it may be difficult. So you have to specifically ask for the history, and if you get such a history, such donors have to be permanently deferred as per the current guidelines of India.
Thank you. So moving to the next question, again, it is on hemoglobin. Who says a male hemoglobin below 13 is anemic? I think that has been already addressed to it. I think this will help. Vitiligo, white patches on skin. What's the take? Should we take blood donation or not?
Yeah, vitiligo or white patches on the skin usually stands for an autoimmune condition. So it is better the donor gets investigated, and then once the reports are ready, we can go through the reports and take an appropriate answer for that.
So again, multiple lipomas. Somebody asked, as me, somebody having lipomas. Should that person be donating blood on again?
Yes. So multiple lipomas is again a benign condition, but you have to be doubly sure that none of these lipomas are turning into a precancerous or becoming into a malignancy. So you should palpate all the lipomas, and this like multiple lipomas is usually a genetic condition with a predisposition to go in for a lipomatous change. Like it can go for a lipoblastomatous change, it can undergo. So such donors should be accepted with caution. Only if you're doubly sure that all the lipomas in the body are benign and you have looked at all the lipomas, I think you take a decision. These are all based upon individual. I think the physician can take a decision on this.
Thank you, Dr. Amita. I think we have covered all the questions which were asked. And there's lots of hemoglobin questions which are there in the chat box. And I'm happy that Debashish sir is here. He's already addressed that issue. So over to you, sir. I think all the questions are, if there is no questions, I ask sir, please.
Good. Thank you, Amita, and thank you, Rahul, for giving so much of clarity about the blood donation selection criteria pertaining to the Indian scenario. And I can assure you that we as a TRG has taken adequate step in answering all your questions, and very soon the donor selection criteria will be published and released by the DGHS. Okay. But one thing which I want, as a comment, I just want to say to all of you that one of the important general principle, which Dr. Amita has mentioned in her presentation, that the donor care is a very important aspect of the blood donation. Whether when a donor comes to a blood center to donate blood, he may be either deferred for donation or he may be selected for donation. As of now, the donor who have been selected for blood donation, they are getting adequate care by the transfusion medicine department in the donation period, also in the post-donation period. But here we are seeing that those donors who are deferred, though they are being labeled as a blood donor, we are totally ignoring their donor care. Okay, whether they have some sort of medical ailments or any sort of other diseases, or they under medication, what sort of donor care? There should be something when we are talking about so much of now there are a lot of OPD has been opened in the various centers in the country. Okay, but we are not trying to address all these donors who are rejected or deferred for some medical reason. They can be sent. It will not be possible in the blood center or in a outdoor blood donation camp to give them all the medical advices and everything. But it is one of the good things that they can be referred to the system. Now recently SCTIMST has opened his OPD clinic. Prasoon is operating, and so many other centers are also going to open the OPD clinic. I think there we should take an initiative in giving a proper donor care for this. So because the temporary deferral which are there, how soon they can be brought back to the donor pool, that we are not addressing. Okay, so those things, like there's when Amita is also present, the many of the countries which are giving a donor care, you have mentioned in that one. Okay, it is so nicely they have done that, the iron supplementations, everything they are giving it. So those things also should be introduced in our country. Okay, and that thing we should take into at the level of our technical resource group also, that this should be framed and put it into place. Okay, so that the donor gets also motivated that okay, they are being given the most care by the when we go for the blood donation, and this is what the things are there. Okay, plus those are permanently deferred. We are not able to counsel them that very properly, that whether they agreed for not going for further donation, or they go to other blood center and donate and hiding those things. Those is all because of not proper donor care is being given or provided by the blood center. So that is what this is the area which need to be addressed and need to be seen in a very diplomatic and should be implemented.
Very much, sir. We still have questions coming up. Just I think I'll take up these two questions and we'll close the question session because we're already at 1 o'clock. Dr. Amita, there's a question.
Another 5 minutes or 2 or 3 questions we can take.
Topical antibiotics and the deferral criteria, as well as for oral antibiotics.
So why do we give antibiotics? Antibiotics are usually given for an infection. So you look at the infection. If you think it is not going to harm the quality of your blood component and it is not going to harm the recipient who is going to get the transfusion, then you can accept it. But if you think it is going to harm, it is better to defer. And oral antibiotics, because it reaches the like blood, and there may be bioavailability in the blood also, that also needs to be taken into consideration, particularly when you are giving to a patient with a like compromised renal or liver functions. So that also needs to be taken into account.
And plus also the platelets is also a source where we have to be taken into consideration.
One is the intra-articular painkiller injection deferral lasts 3 days or minimal procedure.
So again, I think here also we do not have a clarity of our donor selection criteria. So that needs to be like addressed on a case-to-case basis.
Is a painkiller means the patient will be having something sort which can have an antiplatelet. So we have to see that that particular patient should not donate platelets or any other platelet-related thing. So that it should be subjected only for the plasma or the red cells.
The same thing goes with PRP. Post-PRP injection, somebody is asking the person donate or not.
PRP.
Yeah, you tell Amita.
Yeah, post-PRP in our, like there is no guidelines available, but individual centers can develop their own guidelines. So post-PRP injection, we take it as a minor procedure and we defer for 6 months because most of the PRP is autologous PRPs. So we keep a deferral for 6 months.
So I think we're done with the questions, sir. If you allow, then we can close the session and thank.
Yeah, I think the questions, those things which are Canada has updated the guidelines for cocaine. I think these are not because the drug abusers we are not going to be permanently deferred. So there's a very question. It's not a question to be answered. With the Conada rules, we should not follow them. We should have our own thing. Okay. And thank you very much. Thank you very much for the very good presentation, Dr. Amita, as well as giving the replying to all the answers as laid on the participant. I think the participants are very benefited by your presentation, and they have come to know about what are the things, how the donor care, donor management, donor selection is being undergoing throughout the world. Okay. So that is a very eye-opener for many of the us, particularly I think the PGs who are attending to this particular webinar will be much more benefited. And thank you, Rahul, for moderating this webinar. And I wish all of you the best. Thank you.
Thank you, everyone. Thank you, Dr. Amita. Thank you, sir. And a big thank you to the team from ISTM who has been coordinating this to the backend. Thank you, Dr. Deepti. Thank you. Thank you all the attendees for this, for attending the. Thank you. You can close if